52-year-old Mrs. B from Tirupattur, a housewife referred from a nearby hospital with a history of 1 week of fever with chills and 1 week of abdominal pain and 2 days of worsening breathlessness. The fever was high grade, associated with chills, continuous, not settling with the over-the-counter drugs, and she developed breathlessness also, after which she went to the nearby hospital. And the abdominal pain had a characteristic of diffuse and dull-looking in nature, and she's a known diabetic who was on irregular drugs since 20 years. And at arrival, she had a BP of 130/80, the pulse rate of 90, and respiratory rate of 24, and the temperature of 101. And there was pallor, and she was tachypneic with no pedal edema, lymphadenopathy, icterus, cyanosis, and clubbing. Examination of the abdomen, there was a diffuse tenderness with no free fluids, and there was no renal angle tenderness initially. And examination of the respiratory system showed bilateral infrascapular crepitation, and S1, S2 was here normally with a GCS of 15/15 was seen. So she presented with fevers, with chills, and with worsening breathlessness with abdominal pain. The initial differential considered were fever with acute cholangitis or liver abscess, or acute pyelonephritis, or acute renal abscess. Later on, moving on to the investigations, she had a leukocytosis with predominant neutrophils. However, her urine had only WBCs of 6, and there was indirect hyperbilirubinemia with elevated alphas, and urea was elevated with thrombocytopenia was noted, and D-dimer was 9,232, and UST abdomen done initially was a normal study. So from this, there was a left shift plus thrombocytopenia plus indirect hyperbilirubinemia favoring a state of sepsis. The next day, when on examination, she developed a right renal angle tenderness, and since already the ultrasound done was also normal, went with a CT that has showed a ill-defined heterogeneous echogenicity in the right kidney, which on ultrasound had a liquefied content showing right renal abscess. And also she complained of severe low backache. On examination revealed point tenderness over the L4, L5, and S1 area. X-ray was grossly normal. We went with MRI spine, which showed features of the osteomyelitis involving L4. So at this point, the patient blood culture has grown E. coli, which was a ESBL. So she was a case of E. coli septicemia with right renal abscess with vertebral osteomyelitis. Looking into the acute vertebral osteomyelitis, the incidence accounts to 2.4 cases per 1 lakh population, and it is mainly due to the hematogenous seedling or otherwise direct inoculation at the time of spinal surgery or continuous spread from an infection in the adjacent soft tissue. The primary focus of infection usually being urinary tract or skin. The risk factors predisposing to the conditions are diabetes, coronary heart disease, or other immunosuppressive disorders like malignancy, or renal failure requiring hemodialysis, or use of intravenous drugs. And the organism usually isolated were the Staph aureus or the E. coli, as in our case. So blood culture plays a significant role in establishing the organism. The complications usually encountered by these conditions are psoas abscess, paravertebral abscess, or epidural abscess. 1/4 of the people develops neurological deficits. So when to do surgery in this condition? If the blood cultures are sterile and osteomyelitis is suspected based on imaging, or if neurological deficits are encountered, or to drain abscess, or when implant acts as the nidus for the infection, or if there is treatment failure. So what is treatment failure? If at the end of the 4 weeks, if there is no clinical improvement, it is considered as treatment failure. And only if there is a high CRP titer, even after 4 weeks of appropriate antibiotics, re-imaging with MRI is warranted. Why is reassessment important in this condition is 8% of relapse rate is observed with 1 episode of vertebral osteomyelitis, and 6% death rate following an episode is observed. Coming into E. coli osteomyelitis, which is observed in our patient, there are certain case reports and literature review which identify diabetes as a sole underlying immunosuppressant condition predisposing to the study, in which in a study 36% had neurological complications following E. coli osteomyelitis, where in the other study having diabetes of 25.2% had 87.8% full recovery and 12.1% with minimal neurological deficits. So in our patient, we started her on injection meropenem based on the sensitivity. As of now, no focal neurological deficit was observed, hence surgery was not done. Current plan is to give antibiotic for 6 weeks, after which we will decide based on the clinical improvement and adequate control of her blood sugars and adequate analgesics. So to look into the E. coli osteomyelitis, its presentation, risk factors, and management. Thank you.
Sure, nice presentation. The patient actually came with a non-specific fever and illness, right? So it's very important to go back and examine your patients in the ward every day, look for any evolving signs and symptoms, especially if you don't have a cause for something. Any questions, any comments?